Well, good morning, everybody. It gives me an absolute pleasure to introduce my dear friend and colleague, Dr. Joshua Richman. Joshua is an associate professor in surgery in the Division of General Surgery and Gastrointestinal Surgery. He wears so very many hats, and I will tell you which is the most dear to me. But let's talk about all of his hats. So he's the chair of the IRB for the VA. He's also on the VA Scientific Merit Review Board. He's the scientist in the Center for Outcomes and Effectiveness Research and Education. He's what else can I say? He's in the CCTS, Biostatistics, Epidemiology, and Research Design Core. And he co-directs the core methods and design working group. But let's discuss his connection with ICOS. He joined as a member of the Institute in 2016. And so very soon after that, he became absolutely indispensable to us. And he is now the director of the biostatistical services for our institute. And we don't do anything without getting his blessings. He has mentored so many people. He is on grants that go up to the moon and back. And he has published over 200 papers. But most importantly, as I was telling him yesterday, he is most unlike most biostatisticians. And the reason for that is that he carries an MD degree and he carries a PhD degree. So Changde, don't get mad at me because I'm going to badmouth some other statisticians. Joshua, you are most non-judgmental, you're most patient, you talk to non-statisticians in a way that is so understandable. So there's not that Joshua sitting up here and we're sitting down here. It's like very much on an equal level. And we really appreciate that. Very clear thinking and the trust of the ICOS members on what your thoughts are is absolutely immeasurable. So Joshua, thank you. We're looking forward to hearing from you.
I don't want to quit now while I'm ahead. So everyone's had a chance to read Jan Jansson's quote. That's a nice placeholder that he gave me when I said I was doing a methods talk a while ago. He even told me I could use his name. So I think every set of slides from now on needs to include that. He, of course, doesn't believe that, and neither does anybody I've encountered at ICOS, for which I am very grateful. All right. So I was going to talk about ways of thinking through survival and competing risks, because in our world, we do a lot of survival analyses, and competing risks are things that come up all the time, and they're a lot more slippery than people think, I think. So my goal is really, I'm going to sort of follow the podcast audiobook model of things. If you're interested in this topic and I'm at least reasonably engaging, you're going to listen and you're going to concentrate and you're going to learn something. The slides are deliberately sketchy because I really don't want you to spend that much time reading them. In fact, I think if you closed your eyes and just listened in an engaged way, you'll really get just about everything I would want you to get out of this. So at the end of it, I'm going to sort of spin a yarn, and you should feel like you have a better understanding of survival analysis uses and limitations. And even better than that, you actually will understand more about them, along with the feeling of confidence, which I think is the way things should go. So specifically, I'm going to talk about the point of the things that we call survival analysis. I think most importantly, I want to talk about what they're actually doing, as opposed to what we usually think they're doing, especially when we don't think about it too hard. And then I'm going to branch out a little bit and talk about how they incorporate time-dependent covariates, so things that change over time, and competing risks, which are a big thing that people really like to include. People are always worried about competing risks. And we talk about what they are and what they turn into when you put them in a model. There are some obvious limitations here. We can really only scratch the surface and paint with broad strokes. I really meant to start writing my slides on Sunday, and instead I basically spent all Sunday rereading things about survival analysis to decide what I wanted to talk about, which was 10 times longer than I'm going to talk. And that's, of course, just the barest bit of the literature even that I could look at. And what I want to get out of this is I want to remind you of a lot of the subtleties involved and what the broad strokes are here. The ancillary benefit was I really got to spend some time thinking through these things. I had a professor once who assigned an exam years and years ago who said his father, who's also a professor, said, if you don't learn anything from the exam, it's just a waste of everybody's time. So even if y'all don't learn anything from this, I learned a lot having to think through how these things work, which hopefully will help me better explain them here, hopefully, and in the future one-on-one. And these are things that come up a lot even when I meet with their statisticians every Thursday. So even if it doesn't actually help you directly today, it's probably good for me. At least I hope so. All right, so some things I just want everyone to keep in mind. All models are wrong, but some are useful. Quote is from George E.P. Box, who is one of the greater, larger names of 20th century statistics. I'm not sure if he made it to the 21st century or not. I think he didn't, or at least not that much. The other one is this quote, make things as simple as possible, but not too simple. People say Einstein said it. I looked it up apparently, and I like this because of what it says about statistics and the state of knowledge in general. Apparently he didn't really say that, or at least there's no evidence he did. He said related things, but then it was refined and made pithier by people who quoted, paraphrased, and whatnot. So you can buy a mug that has that and attributes it to him, but it probably doesn't actually belong to him. All right, so first question is, what is survival analysis for? I also want to say, feel free to jump in and ask questions if I say something that makes no sense or you are totally at sea. And even if you think I said something wrong, I'm happy to be corrected. Sometimes I do that. So what's it for? We also call survival analysis time to event analysis, which comes in how we think about it. And I think also a little bit of disconnect between what we think it does and what it actually does. The intuition is that it's a way to deal with events and outcomes that are, and death or survival is really the canonical example of where this comes. So events that are not very common in the short term. People, thankfully, in our day-to-day life are not dropping dead all the time. They will happen eventually. We don't like to think about it too much, but we know everyone is going to die at some point. And they may only happen once. This is especially true of mortality in our experience, but other things like you're really worried about the first time something happens, like how long till somebody gets cancer, how long till someone has a heart attack. None of them happen all the time. There's a pretty high probability, very high probability for death, pretty high probability of significant comorbidity over time. And they either happen once or you're really interested in the first time it happens to someone for whom it hasn't happened before. So the question is, why not use logistic regression? Everybody's pretty comfortable with logistic regression. I would say for good reason. It's easier to be comfortable with it than it's survival analysis. So if you're interested in a specific time period, like you want to know what happens within 1 year from your start point. So maybe you want to know 1 year mortality after someone is diagnosed with cancer. So you've got a short period of time, and there are a reasonable number of outcomes in that time, and you don't lose anybody along the way, meaning nobody disappears, so you have complete ascertainment. Then you really could use something like logistic regression. You're modeling how often or what are the risk factors for somebody not making it to a year, right? And you have, for some conditions, there are a reasonable number of outcomes that you could model that, and you may not actually be that concerned with when things exactly happen. It may not make a difference to you in your research question whether someone dies 5 months after diagnosis or 11 months. What you really want to tell people about is what are the risks of not making it for a whole year. So in those cases, you could absolutely use logistic regression. But what if you cared about longer follow-up, especially with differential follow-up? And we know we have this in things like the BMTSS study and many of the things that everyone in ICOS does, where it's hard to enroll people. It takes time to collect data. You want to follow them for as long as possible because certain outcomes like mortality don't happen all the time, or recurrence, or secondary neoplasms. And some people, so you've got long follow-up, differential follow-up. Some people, what's the range? Smita, for BMTSS? Some people have been followed for 10 years. Some people have been followed up to 30 or more years.
43 years.
43 years. So we've got a long time. Obviously, if you follow someone for 43 years, they're more likely to have an event than someone who's only been followed for 10 years. Or when outcomes accumulate more slowly. So for example, if you wanted to cut off events in BMTSS for 1 year after enrollment, you won't have nearly enough events. We barely have enough events for some things we want to look at now, and that's following some people for 40 years. So logistic regression would not work with this shortened time frame. And people do get lost, which in the survival world you call censoring. You lose them to follow-up, you don't know what happened to them. You're interested in things like developing a recurrence of cancer, but they die of something else along the way, so they are in some sense lost to you for the purpose of recurrence of cancer. Then logistic regression is not the appropriate thing, especially with censoring, which is something that logistic regression and standard regression methods really just don't know how to deal with. Oh, back up, sorry. Also, in a deep way, logistic regression really, I put it usually in there because there are things you can sort of fudge in ways you can kind of sort of deal with this, but none of them are really satisfactory. Logistic regression doesn't actually care about when the events happen within your interval of time. It just cares whether they happen or not. And there are certain ways that survival analysis does deal with when things happen. There are other important ways in which it doesn't deal with it as directly as your intuition says it should. But I'll get to that a little bit. All right, so the first effort of survival analysis that everybody learns is Kaplan-Meier plots. You all have seen these things, you know what they are. They are a non-parametric model of the survival curve over time. So this is something I think I actually did for somebody through the CCTS, where we were looking at survival after some kind of ophthalmologic procedure. And these are stratified by the reasons they had their procedure. Are y'all seeing the little pointing cursor? Okay, cool. Can't tell if it's tracking. So everyone is alive when time starts, and survival decreases over time. It decreases a little bit differently for both of the things, both of the groups. And I think everyone's probably reasonably familiar. The people I can see are sort of nodding like, yes, I've seen these before. So they're non-parametric, meaning they don't assume any shape. And they really have a lot of the key elements that follow into just about every survival method. Those are, there's a start time right here, time 0, where everybody should be at risk of your outcome. It makes no sense to have a start time where people aren't at risk, because then events can't happen, and it's hard to model things that don't happen. It just, in some very deep way, doesn't make any sense. So at each time point, changes in the survival function are based on the risk set, those people who are still in there, who haven't had an event and haven't been censored. So every time there's a little jump in one of these curves, it's because an event has happened to somebody, and then it recalculates how much of a drop there is in the survival curve based on everyone who's still in there and at risk, up to that point as far as we know. So if someone is censored somewhere in the middle here between two events, they're not part of the calculation of how the survival curve changes when someone does have an event. And that's how censoring is dealt with. And I say this to people all the time, and it's super easy to accidentally violate this law. The data should never, ever, ever, ever look into the future, no matter what happens. So what it's doing is, when somebody has an event, it figures out how much to change the survival curve based on everybody's characteristics who are still at risk right up until the point where that person had the event. Should never, ever take into account something that happened afterwards. So for example, here, the stratification also should obey that. The stratification was based on the indication for their procedure, as I recall. So that is something, you know, when they go into the OR to have their ophthalmologic thing done, you know why they're having it done. So it's something, you know, at baseline, you stratify on that and you move forward. So I'm going to give you an example. There's a study from an unnamed prestigious university. I mean, I know the name because I read it in the book this Sunday, and I've read it many times over the years, that was looking at the association of heart transplantation and mortality. They did Kaplan-Meier curves and survival analysis stratified by transplantation, yes or no, and their time 0 was based on enrollment on the transplant list. and they found a huge benefit of transplantation. Anybody see any issues with that? Y'all would have to unmute to tell me if you saw any issues.
Feel like there's an immortal time bias.
Right. There's immortal time bias, which is another way of saying they looked into the future to stratify, right? If you start time 0 at enrollment on the transplantation list to be eligible for a transplant, but then you stratify by based on whether they actually got a transplant. To get a transplant, you have to live long enough to get a transplant. So they have put people, they've looked into the future to stratify their groups. And that leads to what's called immortal time bias. To get into one group, you had to live long enough to get into a group, and that time was after time 0. Exactly. Perfect. Example 2, this one's sort of a generic example I pulled out of my memory this morning when I was reviewing my slides and thinking what I wish I'd said. There was a study that did survival after breast cancer diagnosis, and their main exposure was completing chemotherapy, but the clock started running at diagnosis. So this again has a very similar problem, right? Because you're stratifying based on having completed chemotherapy, which means not only did you complete it, you lived long enough to complete it, and you didn't have any events that made someone stop early. So it's stratified where one group, it could only be known long after the start time that they completed treatment successfully and made it long enough. So that group's outcomes are biased to be more favorable because it relies on looking into the future. And honestly, it took a while before people started to really realize and formulate these things, and they're still really easy to violate if people are not careful. So other assumptions about in survival analysis for it to be valid, you generally have to assume that censoring is not informative, meaning people who you have lost a follow-up for, you should at least be able to plausibly make a case that they're not different from people who aren't censored. Sometimes it's harder to make that case than others. A lot of times you can understand that people who are sick may stop coming back in for follow-up visits because they're sick or they've lost hope, and that's related to the fact that they may be having worse outcomes in the very near future. I think it's an easier case to make sometimes for death when that is your outcome, because there are such good national records for death. Like it's a lot harder to, or there's less reason to worry that you're not going to ascertain that outcome because of public records. But if your outcome is something else, it can be a tougher thing to think about for whether your censoring truly is non-informative. Another form of informative censoring are when there are competing risks that you know about. If you want to model death from one cause, then the original approach for when someone dies from something else is, well, they're no longer at risk, so they should be censored. But that is in some sense informative censoring, because the fact that they've been censored for competing risk means you absolutely know they're not going to die of the cause that your study is for. So you can't really say it's not informative. Another thing to note about the Kaplan-Meier curves is they're not adjusted for covariates, but they can be stratified as they were in that thing. And you can test for differences by the strata using the log rank test. So it's easy using Kaplan-Meier curves to divide people into groups as long as you know what those groups should be at time 0, and test for whether their survival curves differ over time. But we really like to adjust for things, especially lots of things at the same time, and you really start running into small numbers issues if you want to have 12 different strata for your Kaplan-Meier curves. In addition to having small numbers, they just gets really crowded and you can't even see all the plots together. It just doesn't make any sense. So the key insight, mathematically speaking, of how you start to be able to deal with this is to realize that the slope of the survival function, that decrease in survival and how quickly people die or have events, is related to something called the hazard. And informally, the hazard, which everyone's heard of because we talk about hazard ratios all the time, is informally, it's the probability of having an event in a short period of time among those still at risk. So it's the rate of events for you walking around today conditionally on the fact that you've survived long enough to be walking around today without the event. That's the hazard. So it's this sort of short interval risk things. So hazard functions are expected to change over time. Obviously, some things have increased risks of dying early that decrease over time. Others have low chances at first, then increase, et cetera. I think most famously, the hazard of dying throughout the course of life of a human being is U-shaped. It's higher very early in life, and then it flattens off. It's probably a little bit different for teenage males who have risky behavior sort of in the middle. They probably have a little bump in their half-formed mental teenage years. And then it increases again as you get older, when your hazard of dying as you become older and older increases. This was actually the first project that got me hooked into ICOS with Dr. Wolfson. And here we actually modeled non-parametrically the hazards of relapse in children and adolescents and young adults by their era. So the era of diagnosis with cancer was earlier was solid lines, later were dashed lines. Children are in red, AYAs are in blue. And here you just see that I wouldn't have wanted to guess what shape these had to begin with. So this is especially like while people were on therapy, you can see the AYAs were higher at the beginning. It differed by what era they were. They came back together regardless of the era after about 15 months on therapy and then went down. The kids looked very different again, both from the AYAs and by era. So this is why you, in some ways, you don't know, I think, really what hazards should look like. You can model them, but I wouldn't want to guess offhand what they would. Okay, but if you know somebody's hazard because you've modeled it or you have a reason to assume it's a certain function, you can estimate. Sometimes we call that predict, although I don't think anyone's really good at predicting survival time in the long term. You can estimate their sort of expected survival time. Somebody who looks like this will live on average 55 years, plus or minus a wide variability. And then adding covariates can increase the hazard. So again, if you've specified the hazard, covariates can show you that maybe you increase the hazard, and this is interpreted as sort of accelerating the time to failure or accelerating aging, which leads to one of the earliest ways of doing survival analysis, which is called accelerated failure time models, which are still used and they still have their good purposes. They still assume that censoring is not informative. They assume a parametric hazard function of some general shape, according to lots of different distributions. It can be an exponential distribution, Weibull distributions, gamma distributions. And then the covariates are looked at, as I said, in terms of accelerating the failure time. It still also assumes that the values of all covariates are known at time 0. And generally, they also assume there's only one outcome of interest, so no competing risks. The biggest liability they have in terms of modern usage really is this assuming that covariates are known at time 0, because a lot of times we know that there are covariates we care about that are not known that far ahead, or that not known at the baseline and never change. Okay. And the other issue is that they assume this sort of parametric hazard, right? And like the slide I showed you where we modeled the hazard, I wouldn't have guessed any of those shapes to begin with, and they're different between groups. So if you don't want to assume the shape of the hazard, you don't want to define it parametrically, that leads down the road to Cox regression, which is what most of us do 98% of the time for survival analysis, also known as proportional hazards regression. What it does, and there's a little bit of math coming up. I tried to like glaze everyone's eyes just a little bit, but not too much. It assumes that there's a baseline hazard, this thing, h sub 0 of t, that's a function of time, that's common for everyone, that's then adjusted by covariates. So at the tth time, the ith person's hazard is this baseline hazard times the exponential of beta coefficients and their covariates. So their covariates are the x of I. This is the ith person's covariates, whatever those are. So, but keep your eyes on baseline hazard. So there's a lot of gnarly math involved, but very much like the Kaplan-Meier curve, and I'm just showing you the heuristic math here, not the real math. Like the Kaplan-Meier curve, what Cox regression models do is whenever somebody has an event, it compares the hazard of the person who had the event to the hazards of everyone in the risk set. So to make a likelihood function. So imagine the first person, that's this guy over here, or gal, whatever, has an event at time 5. So their hazard is the baseline hazard at time 5 times the exponentiation of person number 1's coefficients. You divide that by the sum of everybody who was at risk at time 5. So you include person 1 who had the event and everybody else who hasn't had the event yet. So if it turns out that person 1 has a bunch of risky covariates, this is going to be relatively large compared to the sum over everybody else if they had relatively non-risky covariates, because each one of their terms will be relatively small. So you can think of it as saying, every time someone has an event, it estimates this quantity. How likely is it that this person who had an event was the person who got unlucky and had something happen to them at that time compared to everybody else?
Joshua,
Yes,
can we ask some questions here?
absolutely.
So suppose there's missing covariates. How does this equation handle that?
So Cox models, like other regression models, will drop people if they have missing covariates. So if you assume that you need a covariate in there and someone has an incomplete observation, they'll get dropped.
That person will get dropped.
Yep, just like other regression methods. You can do imputation with Cox things and other things, but they'll be dropped.
Thank you.
Because you can't calculate beta times all of your coefficients if you don't have all your coefficients. All right, so this is like the last bit of the eye glazing math. So what I just want to point out is here's that thing I showed you before. Everybody who did fractions in junior high and high school says, aha, you can pull out this baseline hazard at 5 from the top and from the bottom. And when you pull out two things that are the same on the top and the bottom of a fraction, they cancel out, and poof, the hazard is gone. So the really beautiful, crucial trick of Cox proportional hazards regression is it says, we don't actually have to know the hazard. Not only do we not have to say it has a parametric structure, we don't even have to know what it is. We don't have to estimate it. We're just going to deal with the relative hazards. And you use these quantities to estimate what the beta coefficients are to maximize this likelihood. Okay, so that's Cox regression. It assumes that everyone's hazard is proportional to a baseline hazard. With that assumption, you no longer even need to estimate the baseline hazard. It still assumes in its original formulation there are no competing events. And what's also interesting is the time of the events no longer matters. It's just the order of when people have events now and who is still at risk. So if you look at this thing, your beta coefficients and their contribution to the risk don't change over time. So, and this thing is the only thing that matters for time, where you are on the hazard function, but that goes away. So the only thing that matters really is when each person has an event, it matters who's still in the risk set and hasn't had one yet. So you can stretch out the event times by multiplying them all by 1,000. You can move them around by random noise as long as you never make Mrs. Smith have an event after Mr. Jones when originally hers was before Mr. Jones. As long as you keep the order the same, the time is actually no longer part of this at all. All right, so interpretation coefficients from Cox regressions are exponentiated to make hazard ratios, which is what everyone reports and everyone feels comfortable talking about hazard ratios. When you have fixed covariates and you don't have competing risk, a higher hazard ratio translates into higher incidence of the outcome, which is why it's easy for people to say in classic Cox regression, when you have a higher hazard ratio, people say you have a higher risk for the outcome. That's absolutely true. Now, what you can't say, and people want to say this all the time, a hazard ratio of 1.5 does not mean the incidence or risk over time is 1.5 times greater. So it doesn't mean that 1.5 times as many people will have this event over time. It's a hazard ratio. So it's talking about your instantaneous risk over a short period of time. How much that translates into a different actual overall event rate over the course of follow-up depends on the actual underlying shape of the hazard function, which Cox regression is actually explicitly deciding it doesn't care about. And of course, if you think about it well and truly in the context where your outcome is survival, you know they're going to converge again eventually. If you have two groups and you follow them forever, everybody is going to meet the Grim Reaper. So no matter how separate these curves look at the beginning with proportional hazards, you know they're going to come back together eventually. So that's, if you keep that in mind, you'll remember like a hazard ratio can't actually translate into that ratio of events over the whole course of time. All right, but the thing is, things change, right? That was the easy version when life is possibly too simple of knowing your fixed covariates at baseline and having them never change. We know that if we follow people for 5, 10, 20 years, covariates can and will change. There's an easy fix within Cox regression for this. We had, I swear this actually is the last bit of math. Originally, we had our baseline hazard as a function of time times this thing of our covariates, which were just fixed for each person. At each, when you measure those likelihoods, what you can now do is make sure that the covariates are a function of time. So when events actually happen, you just use the current value of time varying covariates in the likelihood. So if your original covariate was when the clock started running, does somebody have diabetes? And the answer was no. If you assume that those covariates never change, the value is always no whenever someone had an event. Now what you can do is say, all right, person number 12 got diabetes 7 years in. So anytime an event happens after 7 years and they are still in the risk set, person number 12 now has a covariate of yes for diabetes. That's really all that happens in time varying covariates. I meant to put a slide sort of illustrating what this is a data structure for this, just because it's useful to me. It may actually not be useful to anyone else, so maybe I'm glad I didn't. SAS and R have very different ways of doing that. SAS sort of deals with this as an internal data step within the procedure for doing survival analysis. R much more explicitly sort of makes a data set that has that underlying structure. As an R person, I prefer that and think it makes more sense, but the SAS world does not agree, and that's okay. All right, so going back to a more concrete example, that heart transplant study, when you look at it this way, it makes a lot more sense to handle transplantation as a time varying covariate, right? You should start, it makes sense to start the clock running when someone enters the transplant list, because that says this person is so sick, they should get a transplant. There's not much else we know what to do for them. But what you really are interested in is once they get a transplant, does that have something to do with their survival from that point on? So when they did the analysis this way, and literally I left that book that I used for the source for this at home this morning when I realized that I wanted to add this to talk about it. So I don't remember whether it was that there was no benefit of transplantation or a much more modest benefit, but in any case, it made it so it was no longer a slam dunk because they were not looking into the future and comparing a group that lived long enough. They were now saying, after you got the transplant, did having been transplanted make a difference compared to everyone who'd made it as long as that person who'd been transplanted? All right, so there's caution. We are now leaving the world of simple things where you know your covariates at baseline and you don't have competing risks and you follow people forward. Now we have covariates that change over time. So when you start having time varying covariates, a covariate that's time varying but a hazard ratio greater than 1, which we want to say is greater risk, it is a greater hazard. If you walk out your door with an increased hazard, it is more likely that in the very short term near future, you're going to have an event than someone who has a less risky covariate. But it may not be associated with an appreciable increase in the actual incidence over time in your cohort, because that depends on when you were exposed to your time varying covariate, when it changed, what the hazard looked like when it changed. You can easily imagine the hazard is really high early on, but your covariate doesn't become risky until the hazard is much lower later on. So it depends when your covariate flips for how much of an effect it actually has. Another temptation that happens is you still may never, 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 ever look into the future. So it's tempting for time varying covariates. You know, if you have a time varying covariate measured at year 5 and year 10, it's tempting when an event happens at year 7 to want to impute a value at year 7 that's like halfway between year 5 and year 10, but you can't do that because that's looking into the future. You cannot let year 10 inform what you call something at year 5. So you have to essentially carry your last observation forward from year 5 or something like that that does not actually look into the future. All right, so there's a certain simplicity to survival as an outcome, which is what motivated all this. We mentioned we're all mortal. As time runs on, the survival function will go to 0. And cumulative incidence, which is the flip side of survival, goes to 1. We know if we follow people long enough, the cumulative incidence of mortality will go to 1 in the same way that survival goes to 0. This leads us into the world of competing events. So sometimes death is not the only outcome we're interested in. So sometimes we're interested in, say, specifically dying of cancer, as opposed to dying from something else. The cumulative incidence of dying from cancer does not actually tend to 1 over time, because people do, in fact, die from other things, right? Which is equivalent to saying that the survival function of dying from cancer does not go to 0. It goes somewhere else. There's only a certain proportion of people who die from cancer. So things to think about with competing events, also called competing risks, are you have to think about, are they really competing? To know if things are really competing means one really has to rule out the other. Dying of cancer does rule out dying of a heart attack if you set aside issues of like by what mechanism you die from cancer, which could in fact involve a heart attack, but you know what I mean. Like, to the extent that you can separate these things, you can say if you die of one cause, you're not dying of the other cause. This gets a little dodgier, especially when you have non-lethal competing events. Like getting diabetes does not actually strictly compete with getting lupus, right? You can get both. But if you're interested in the first new comorbidity, like what are you likely to get first, then if you get diabetes first, you can't actually get lupus first. So it becomes very tricky to make sure that you correctly frame the question that you're asking when you want to talk about competing risks and you have things that don't preclude each other. You then have to think about modeling very carefully what is first and interpreting things that way. So if you ask yourself that question and you say, well, you're interested in the new comorbidities, but you're not actually necessarily interested in which one was first. Oh, that's a terrible typo, unnecessarily. Then you can account for the other comorbidities by time varying covariates, right? If you're interested in whether someone gets diabetes over time, you can adjust for lupus and other outcomes as time varying covariates to see whether getting them along the way is a contributing factor, but it doesn't make sense really to think of them as competing risks because they don't compete. All right, there are 2 main approaches to competing risks. There is cause-specific Cox regression, which is a very sort of counterintuitive name because when people think about it, it usually is not dealing with particular causes. And then there's fine-gray competing risk regression, also called subdistributional hazards regression, which talk about a little bit. These are where things get really interesting. So cause-specific Cox regression treats competing risks as a censoring event. So it allows you to estimate whether something is associated with a hazard. So again, it says if someone is out there walking around who is still at risk for an event, are they at higher risk based on their covariates than somebody else? Censoring is informative, and that does cause a bias in the overall survival or cumulative incidence estimates if you're just censoring people who suffer competing risks and competing events. The hazard ratio, again, your estimate risk of walking around today, is something bad going to happen to you. That's generally fine, but it's a different question than asking how likely are you personally going to be to experience this event over the course of your life. What fine gray and subdistributional hazards do is they look, for example, if you're looking at cancer-related death versus all other causes, where you treat them as competing risks, it looks at the subdistributional hazard of cancer death, for example. So that is the rate of cancer death among those who have not yet died of cancer, which is different from the usual Cox regression one of the risk of having an event among people who haven't had any event. Here, you're interested in the risk of dying of cancer among people who haven't died of cancer. And crucially, what this means is you have to keep people in your risk set who've died from something else. And you're treating them as at risk of dying from cancer so that they will keep that survival function from going to 0, or keep the cumulative incidence function from going all the way up to 1. It's counterintuitive. It kind of annoys me. It doesn't make any sense in the real world, but it does make sense from the perspective of estimating a cumulative incidence function.
Can I ask you a question here?
Mm-hmm.
So for mortality, it's obvious, it's counterintuitive. But how about for morbidity?
So again, I think there the issue is
Cause-specific morbidity. Yeah.
the issue is if you want to look at it in terms of, even if you look at it in terms of what is your first new comorbidity,
Mm-hmm.
if you've already gotten diabetes as your first new comorbidity, you're no longer truly at risk of getting anything else as your first new comorbidity.
Right. But suppose you were interested in the risk of the hazard of developing diabetes, no matter when it occurs and the order of morbidities in that person.
If you're interested in the hazard, then that's when you can use a time varying covariate. So I would say, like, if you're really interested in, like, what is your hazard of developing diabetes, and you want to account for other comorbidities people have accumulated along the way, I would account for those as time varying covariates.
So Joshua, you don't think there's any role for fine-grained subdistributional hazards in our lives at
Oh,
all?
no, I wouldn't say that at all. Gonna get there.
Okay.
Can I ask a question? I think we have dealt with this in one of our analysis before.
Mhm.
So from what I'm looking at these slides, so when we do cause-specific Cox regression, we are looking at the hazards of, I guess, like it's probably okay to report hazard ratios. Whereas if we are doing subdistributional hazards, we should be reporting rates or cumulative incidence and not hazard ratio in that case.
Well, kind of. So the difficulty is that what you get out of proportional hazards, the fine-grained models, is you get a subdistributional hazard.
Yeah.
Cox regression, you get the hazard of an event, assuming there are no competing events. In the subdistributional method, the fine-grained method, you get a subdistributional hazard. You get the hazard of having this event, assuming that you haven't had this event before. But you could have had a different event before, this competing event, and we'll keep you in the risk set for that. So it's different, and that in the world of non-time dependent covariates, this world where we're still talking about covariates at the baseline, if you have an increased subdistributional hazard, you have an increased cumulative incidence function. And that's where it makes sense. Like, so I think the next slide sort of goes on to this. Or talk about why they're useful. So, yeah, so I went on and said this. So, keeping these people in the risk doesn't make sense on the surface. It does lead to unbiased estimates of cumulative incidence. So if you want to estimate the cumulative incidence and counsel someone, what's your lifetime risk of getting diabetes? Or sorry, what's your lifetime risk of dying of cancer? To keep it simple, as opposed to something else. Cumulative incidence is actually exactly what you want to tell somebody, right? It makes a lot more sense than talking about a hazard ratio. Because what people don't usually want to know in a real sense is what's my increased risk of having an event today or in the next week, which is more like a hazard. They want to know, doctor, how likely am I to die of cancer now that I've been diagnosed? And that is actually absolutely what you get out of cumulative incidence function that you don't get from Cox regression. What it does do is it makes the coefficient interpretations even more difficult than for Cox regression, except in terms of the cumulative incidence function, because now you can say a subdistributional hazard ratio that's elevated is absolutely related to an increase in your cumulative incidence within the subdistributional hazards context. again, reminding you we're still in the world where we know your covariates at baseline and they don't change. We're now about to make things one step more complicated and things get truly, truly messy. But before we do that, so this is sort of a case study slide from a paper by Austin, Lee, and Fine, and it's that Fine truly who was working with Peter Austin on this, the Fine of Fine Gray. So they're working together on this. And this, I just wanted to show, if you do cause-specific regression, like Cox hazard regression, and just fit a Kaplan-Meier curve where you censor people with competing risks and add them together, your two competing risks, this is the sum of the Kaplan-Meier estimates that are not treating things as competing risks, but just censoring people who have competing risks. If you do a Kaplan-Meier curve for all-cause death, it's down here. So this just shows you the bias that you get when you try to estimate survival functions in a Kaplan-Meier or Cox regression context without dealing with competing risks. So it is not the way to do cumulative incidence. It is, I think, a more reasonable way to talk about hazards a lot of the time. And I also want to show sort of the counterintuitive things you can get. So this study, he did a case study of people with cardiac disease, and they were looking at cardiac death and non-cardiac death as competing risks, which absolutely makes sense. They're competing outcomes. And they were looking at a diagnosis of cancer as an explanatory factor here. So what you get is in the subdistributional model, which is associated with the cumulative incidence, cardiac death has a subdistributional hazard of less than 1 that is significant. So it makes it look like naively cancer is protective against dying of heart disease, right? And here is the increased risk you'd expect of non-cardiac death among people who have cancer. So it's naively counterintuitive to think that cancer is associated with less risk of dying of heart disease. It makes perfect sense to think it's associated with greater risk of dying of other things. If you do the cause-specific hazard model, you get just about the same association with non-cardiac death, which makes sense. But in the cause-specific, where you're talking about the hazard of, are you going to die of a heart attack today among people with cancer, you get basically no association, which makes a lot more sense because they're separate events, right? Cancer by itself is not going to make you get a heart attack, so you wouldn't expect it. So it shows you from this example that they're just very different ways of thinking about things. This thing is saying, if you have cancer, what you are eventually going to die of is less likely to be a cardiac event because you are more likely to die of something else, probably related to your cancer. And that's talking about a cumulative incidence function of what you are likely to experience over the course of your life. Cause specific is talking about what are you at increased risk of today? And in the cause specific context of what are you at increased risk of today, having cancer does not really increase your risk of a heart attack. It does increase your risk of dying of something else. So they're complementary and they're different and they just get slippery. So again, fine gray models talk about what's actually going to happen. Then it makes it look like that it could be protective for cardiac death. Cause-specific hazards are the risk at a particular time and show you that cancer is not related to cardiac death. All right, so the most complicated scenario, and I think this comes up at least every month or so when I talk to statisticians, are things with time-varying covariates and competing risks. So most cases, if you have time-varying covariates and no competing risks, there's still no longer a simple relationship between the hazards and the cumulative incidence because it depends on the shape of the hazard and when the time-varying covariate happens. When you have competing risks, the interpretation gets even weirder. And by weirder, I mean sometimes darn near uninterpretable. Among other things, it was already kind of weird that you keep people at risk when they've had a competing risk or competing event in subdistributional hazards regression. Now you have to keep them having covariate values even after they are deceased. So for example, if their covariate, time-varying dependent covariate was their hemoglobin A1C or their blood pressure, if you want to keep time varying covariates, you have to carry those forward even for someone who's deceased in the context of subdistributional hazards. I thought I actually explained this better than I did in the slides. I didn't. I think Peter Austin's paper did a lot of work showing that even mathematically, you cannot really talk about a time varying covariate coefficient subdistributional hazard being associated even with the cumulative incidence function in subdistributional hazards, except in very restricted, very well-behaved circumstances, like where the time varying covariate is something that you control as an experimenter. Like your time varying covariate could be the dose of medication somebody gets in a clinical trial, where you know what it is because you're controlling it and you know when it's measured. But except in cases like that, where it's still kind of dodgy, trying to interpret time varying covariate coefficients and subdistributional hazards is just difficult at best. And in the world of real data that does surprising things, it's just a hard thing to do. All right, so my conclusions, having thought about this with you, hope there are plenty of pitfalls in simple Cox regression, like picking a good start time, justifying censoring, making sure you know who's at risk. Things get complicated with either time varying covariates or competing risks. They get much more complicated when you've got both. So time varying covariates in simple Cox regression is not too bad because you're still talking about hazards. Once you try to move that into cumulative incidence functions with subdistributional hazards, it gets so weird that I think even Peter Austin's recommendations are essentially proceed with extreme caution on how you try to explain this to anybody. So I'd want to give some acknowledgments in further reading. So one of my actual favorite books on survival analysis is this thing called Paul Allison, which is Survival Analysis Using the SAS System, even though it uses SAS, and I really don't like SAS. His explanations are very, very clear. I hope there's an updated edition. The one I have is from the 90s, which is the last time I used SAS regularly. But it also goes specifically, I think, into the ways that you have to code time varying covariates in SAS, which, as I said, is very different from the way R handles it. I cannot say enough nice things about basically any paper by Peter Austin I've ever read. He picks up these things that don't quite make sense on the margins of statistics. Like he did a whole series of papers on propensity scores that are incredibly useful. He also has this series on time-dependent variables and subdistributional hazards, which are they're very clearly written. They can get kind of dense. They reward repeated reading, but they're also they're written in a way that does not have a lot of scary notation, or at least no more than necessary. The two in there are the ones that I used most for this talk. But if you're ever trying to figure out what's going on with statistical method and you find something in Statistics in Medicine, which is one of the best journals I know of for explaining those things to mere mortals, myself included, and it's written by Peter Austin, that would be a good place to start, in my view. He's in Canada. I don't know how he does it, but he's amazing. So thank you. I hope that was informative for at least somebody out there, and happy to answer questions, or at least scratch my head and pretend that I can answer questions.
Thank you so much, Joshua. We'll open this up for questions if we can stop sharing so we can see people.
Hi, I have one question. This is Kara Gakanola, one of the postdoc research fellows. Question for you. So to combat the immortal time bias, I know there's been talk about doing like a landmark analysis. I don't know if you kind of mentioned that a little bit in your talk. Just wanted your thoughts on a landmark analysis, and because we had a project where we did that for PDAC. So I'm just trying to figure out a way to best explain that in the manuscript. So yeah, any advice you could give
Yeah,
would be great.
in my view, landmark analysis is a great approach. And what you're essentially doing, in my view, is you're very clearly defining who is in your risk cohort. And for example, a lot of the survivorship studies that we do in ICOS are landmark analyses, where you say, we're going to start with people who have survived for 2 years after their cancer diagnosis treatment, right? So what you're saying is among people who've made it to that landmark, we're then going to look at what happens next. And as long as you are very clear about that landmark and keep that in mind in your interpretation, it clarifies things immensely. The cost is that you are losing people who don't make it to that landmark. But what you're saying is we're explicitly studying people who've made it to this point going forward. And it's a way to deal with the immortal time bias because you've made it the same for everyone. We're saying, you know what, we know that not everyone makes it to this landmark, but the people we're studying are the ones who've made it that far.
But would this also be called conditional survival?
That's not what I've heard it called, but it kind of is.
But, you know, we very often a patient comes to the clinic and they are 5 years from transplant and they say,
Yeah.
now what are my probabilities of survival? So we've created a series of conditional survival curves for people who survive 2 years, survive 5 years, survive 10 years, in order to be able to show
Yeah.
what their
Yeah,
probability of
in
survival
that case,
is.
that's exactly the same. You have a series of landmarks. You're saying if you make it to 3 years,
Yeah,
then this is your curve. If you make it to 5 years, then this is your curve going forward after that. Absolutely.
thank you.
So I think it's just a way of being very clear about which cohort you're talking about.
Right. Any other questions? Can we keep coming back and asking the same question again?
Sure.
Because, and don't then say that we weren't listening carefully.
Oh, I ask myself these questions all the time.
So I have only one question, which
Mm.
is when can we predict the future? I'm just kidding. It was really helpful. Thank you. I'm actually looking forward to listening to it again if I can.
So I'm going to go back to a dumb question, which is you say that in the Cox regression, when you say that this particular exposure is associated with X-fold increased risk, right?
Mhm.
And you say, don't predict the future. Do you have to, because you take away the hazard and in that parentheses, the T
Mhm.
when you're calculating it, then how do you say at what time then?
Okay, so two things. But it's not you can't predict the future. You can't look into the future for your covariates. But you can try to use them to predict the future, but you cannot weight it in your favor by having looked in the future for covariates that you then use.
So
to
we
predict.
don't have to bind it down by saying, since I calculated it for people who were within 10 years of their exposure, I have to say that it is at 10 years or at 5 years or at X number
Right.
of.
You're saying throughout the course of this follow-up, you have a 1.5-fold increased hazard. And remember,
Okay.
that's not the same thing as risk. And also, like, I think you alluded to the question of what Cox regression doesn't actually care about the hazard per se, but just about every package that does Cox regression will essentially do a version of Kaplan-Meier curves where they're non-parametrically estimating the hazard function. And when you get a predicted value out of Cox regression or want to know how well the model fits, it uses that non-parametric hazard function that's estimated behind the scenes with the covariate estimates to predict whether the model fits and people are having essentially the expected survival times that you would guess they would.
Right.
But-
At another follow-up time, we'll discuss which variables to include in models, how to look at the best fit of a model.
Oh boy, we can talk about whether hazards are truly proportional over time too. That's another.
That's also. I have to go. I'm sorry. You all can continue if you want to. Wendy, you're in charge.
All right, safe travels.
Are there any other questions?
Last question. Sorry, I didn't mean to be late, but I really forgot the time. So I don't know whether you mentioned the pH assumption for the Cox regression. So I just wonder for the Foundry model, should we really don't care about the pH assumption or, because it's going to be misleading or biased for the Cox regression if we don't care about the pH assumption, but the Foundry model, we don't look at the pH assumption.
Yeah, I mean, really, you should. So there's two schools of thought. One is that you should always look at the proportional hazards assumption. The other is that it's not even that important for Cox regression. Like, it's important to know if it's truly horribly violated because things don't make sense at all then. And what you'll see in that is if you do Kaplan-Meier curves stratified by the thing you're looking at, like if the curves do funny things and they cross each other, that's a sign that they're non-proportional hazards. But even if the hazards are truly non-proportional and you don't test for it, what the Cox regression will give you is sort of an average hazard ratio. And usually what happens if things are not proportional is it sort of averages out and your average hazard winds up being close to 1 because it's important at some points and not at others. There are ways to essentially do a landmark analysis where if you find that kind of thing, you can say, well, it looks like in the first 5 years, this factor is associated with increased risk. So you do a regression there and then do another one after that as another landmark analysis. And I guess the thing like Allison in his book basically said kind of what I agree with, which I'm sure is confirmation bias among the statisticians' impressions of things of like, yeah, it's important, but it's not that important to check for the proportional hazard.
Thank you.
Well, I have a question that maybe is a dumb question, but going to your heart transplant study example. So
Mhm.
if I understood this correctly, originally the study was looking at people who were on the transplant list, and then they were saying that transplant is better because people survived, more likely to survive if they had a transplant than if they didn't, if they were on that list. But then you said they redid it and they took that out and they started right at transplant. So then what were they if everyone had a transplant, so was it like the underlying condition or what were they comparing?
Okay. So the original way they analyzed it was time started with going on the transplant list, and they analyzed it dividing into two groups of the transplanted versus the not transplanted, which made it look like everyone's transplant was at time 0, which it wasn't. So to be in the transplant group, you had to actually have survived long enough into the future to be called someone who was transplanted, which made that group's survival on the whole look better than the non-transplanted group. But it was because they looked into the future to see if someone was going to be transplanted, and then at time 0, put them in the transplant group.
Ah,
So they had a mortal time bias. They weren't actually at risk of dying until their actual point of transplant, which was some point in the future, because we knew that they lived to be transplanted. And then the way to truly deal with it the right way was you start the clock running at time 0 on the transplant list, and then whether you have actually been transplanted or not is a time varying covariate.
I see. Okay, so they just moved the time back to the beginning when they landed on the list. Is that right?
Yeah, they said that transplantation is no longer defined at time 0. It's defined as of when you get a transplant. It's no, you haven't been transplanted until you actually get a transplant. It's not
Thank
quite the
you.
same thing as moving the time 0 back, because someone who got a transplant after 12 months on the list was still part of the at-risk set for anybody who died, say, at 5 months. But at that point in time, their value for transplanted yes or no was no. So they got included in everything up until then.
Ah, okay. No, thanks for explaining that. Any other questions?
And I forgot I didn't give my like there's no dumb question speech, which I usually give when I'm talking to students, is like there are dumb questions, but the only dumb questions are ones you don't actually care about. Like if you're asking a question to make me feel dumb, that's a dumb question. If you're asking a question you actually wanted the answer, it's not a dumb question.
Okay. Looks like no one has any further questions. We really appreciate this. This was a wonderful talk. Lots of food for thought, and I'm sure we'll come back. So the recording will be available. What I'll probably do is send the link out to the email group for ICOS. If you want, reason why is because we've had an issue with getting them the links posted on our website because the person who did that left. But if you want to get the link to the recording and you're not on the ICOS list, then just email me. I am WCLANDIER@UABMC. All right. Thanks, everybody. Thank you, Joshua.
Thank
Thank
you.
you, Joshua.
Take care.